Hi, Dr. Amar. Good evening.
Yes, good evening, everyone. It's a great pleasure to be here.
Good evening.
Good evening, Dr. Najee, Dr. Robert.
Good evening. Can you hear me?
Yes, we can hear you. Just give me 1 second to share my screen, and then we will start.
Yeah, you have my recording, yeah?
Yes, we have your recording. Okay. Yes.
So I will disappear, but I'll be available for questions. So I'll
very good. Yes, very good.
Okay.
All good. Are we live? Eric, are we live?
Yes, Doctor.
Very good. Okay, so great. So good evening, everyone. I'm Dr. Salti. I'm a consultant anesthesiologist and pain physician in Cleveland Clinic, Abu Dhabi. I have the pleasure today to moderate this session of this series of webinars that we call Pain and Regenerative Medicine webinars. Their series we started 2 months ago, and we'll continue today with great speakers. Today I have the pleasure to know great speakers, and I'd like to share my connections and my network with all my colleagues and in pain community. Today I have the pleasure to introduce Dr. Robert Trapkan, who is a pain physician running a series of pain clinics in Europe, European Clinic. He's a consultant in pain medicine and having a lot of experience in dealing with spine pain. So today I'm gonna ask him to talk about all the new modalities for spine pain and how we deal with spine pain. And I have the pleasure to introduce also my good friend from Iraq. I think he's traveling. He's not with us in Iraq, but he's traveling around the world, and he accepted to share with us his expertise regarding the regenerative medicine and the work that he's doing, great work doing in our region here. He's a consultant hematologist in Baghdad, Iraq, and I had the pleasure to introduce him and to have him as a speaker in our Gulf Pain School modules in UAE, United Arab Emirates. By this occasion, I just wanted to share some news and some information regarding our activities in Gulf Pain School, where we had a great attendance during the 3 series of hands-on and workshop, update on regional anesthesia and pain medicine, 12th, 19th, and 26th of August. Recently, it was amazing experience with hands-on, with great attendance, as I said. And I have the pleasure also to announce that the Gulf Pain School is traveling a little bit away from the region, where we are partnering with the society, American Society of Anesthesia and Pain Medicine, and we will be sharing our experience and expertise in regional anesthesia and pain medicine in Marrakesh in December 16, 17. So you're most welcome to join us. It's under the umbrella of the World Society of Pain Clinicians. And this workshop will be supported by, as I said, by Gulf Pain School and NYSORA team. Again, for Gulf Pain School activities, we are running next month the last module of a series of 5 modules to cover the whole year on training on cadavers and workshops. The next module will be on spine pain management, neuromodulation, regenerative medicine, and spasticity. And this module will end the whole cycle of modules of this year for our colleagues who learned about pain procedures throughout the year. And in October, they will have their review course in order to prepare their exam, the certification of of competency in integrated and interventional pain medicine, which will be in 15th of October 2023. And we was always thinking about the future. That's why today we decided, and we had our planning for next year, April, May 2024, where we're going to have a sort of first regional anesthesia and pain regenerative medicine conference. This time not in Dubai. We're changing to Abu Dhabi, where we're going to have a bunch of speakers, international panel who will join us for this conference. So it's all about pain and regenerative medicine. And I have the pleasure to hand over to Dr. Abkan, who will be talking about spine and new modalities for treating spine pain, including endoscopy. This is where we're very excited to hear about his experience. Dr. Abkan, floor is yours.
Still not in my recording.
No,
So my question is, if you're starting my recording or you want me to start it?
Eric will be starting, no worries.
Okay.
Good evening, everybody. Thank you very much, organizers, for inviting me for this webinar series. And let me start talking a little bit about treatment of the radicular pain syndrome, disc herniation, and maybe a little bit of innovation for the pain management world. So that's my disclosure. I'm Max Moore, instructor for endoscopic procedures. And let's start thinking a little bit from the very beginning, because every time where I'm participating in any congress and if I'm giving a lecture about, let's say, mini invasive treatment of disc herniation and radicular syndrome, always the question about conservative management is coming. There are non-invasive specialties like physio and neurology, for example, and they are always in favor of conservative management. So when you go to studies about this, you will get a lot of results showing very good clinical management or no difference between conservative and surgical management within 12 months time or more than 12 months time. Maybe we can say that the conclusion is that surgical management is a good option for those cases in which patients have debilitating pain and need rapid pain relief, for example, because of sudden motoric or sensory loss. Maybe we can also agree with the evidence base, the results showing that in the long run there is no superiority of surgery over conservative treatment. But then we also come to practical things like who has 1 year time to spend in a bed or to spend with the conservative treatment. And because people, they have their lives, they have to work, they have to make money. There is very few people really able to wait for a long period of time, and most or many of them, they really need quick action to come back to work, to make money, to support the family, and so on and so on. So that's why I think this need of conservative or surgical treatment is an individual thing. And we as medical doctors, we have to find the right answer when conservative and when surgical treatment is the correct option. There are more and more discussions about mechanism of resorption in lumbar disc herniations. And if you go to all the literature, you will find many mechanisms, descriptions, and situation when lumbar disc herniation can resorb spontaneously, which I fully agree with. Also, you see in your clinical practice that before there is any resorption and improvement of the X-ray image of the disc herniation, clinical symptoms can disappear much earlier than absorptions of the herniation happens. So it's very important to think and to realize and to keep in mind that there is very little correlation between magnetic resonance images and clinical symptoms. And that's why it's really a good idea to give the patient a chance to have a conservative management. Regarding reabsorption, I think it's very important also to know or to see what kind of structure is the herniation is having, if it's more hydrated, less hydrated, and then accordingly you are thinking about type of management. But the basic principle of reabsorption of absorption of the disc herniation fragment is that you are activating some kind of autoimmune action. There's secretion of special factors from macrophages, and those are actually somehow cleaning the epidural space from the fragment, and then the fragment, if it's not existing, is not causing any more inflammation and any more mechanical pressure on the nerve. This is actually the type of philosophy which is a little bit against the use of epidural corticosteroids, because epidural corticosteroids are working against the inflammation and against the resorption. But they're also, if we go to this type of question, if we are supposed to use or we're not supposed to use transforaminal epidural steroid injections, this is still a golden standard with good clinical results. If we go to evidence-based, we see that we have quite good results with injections of corticosteroids. And again, from my clinical practice, I have to say that there is some kind of anti-inflammatory effect, and if the fragment is really hydrated, the corticosteroids are really supporting or helping to dehydrate the fragment to get him smaller in size, and this is also taking away the mechanical pressure on the nerve. So in some situations, corticosteroids are still helping the patients, and I would not say right now we are supposed to stop using them. Surgery is a sensitive topic, of course. The question is, do we need a surgery for treatment of disc herniation, or if we need it, we go for full endoscopic, or we use a conventional microsurgical therapy. We have had this discussion with spine surgeons for many years. Despite many spine surgeons, they also perform full endoscopic approach instead of microsurgical therapy. I don't want to go into this, because if you go to any type of literature, you will find that full endoscopic and microsurgical therapy is plus minus equally good regarding the clinical results. I think I'm not lying when I say it's correct on prime surgery, but when it comes to repeated surgery because of any reason that you have reherniation or more reherniations, if you use endoscopic approach, very seldom you will get any problem in form of post-laminectomy or so-called failback surgery syndrome. And on MRI, even after 5 reoperations, you will almost hardly find the signs of any surgery performed on a patient. You will not see any muscle damage, and you will not see any fat degeneration of the muscles. So this is the difference between any type of open surgical approach and endoscopic approach. When you don't cut the tissue, you only dilate the tissue, and you don't damage blood vessels at all. To give you a little bit more information about endoscopic procedures in interventional pain management, it's not just disc herniation. We are able to do endoscopic facet joint ablation. We are able to do SI joint denervation. Of course, we are able to treat disc endoscopically, either if it's problem with herniation or if there is some kind of discogenic pain problem. And we still have in portfolio epiduroscopy for type of diagnostic or some treatment options within the epidural space. What is the inevitable part of indication process for any type of procedure, including endoscopic procedure, is a correct diagnostic loop. So before you indicate your patient for example, endoscopic discectomy or any type of discectomy, it's very important to collaborate with all the specialties being correctly involved in the diagnostic and therapeutic process. You are supposed to use the advantages of physiotherapy and so on and so on. And before you make your final decision about surgery, you have to be sure that you have done everything to avoid the surgical treatment. If it's not possible, you see on this simple diagram that this is only small part of the diagnostic and the treatment options we're using for people with radicular pain and back pain within this diagnostic and therapeutic loop for patients. I said at the very beginning that the question is, the first question when a pain physician is giving a lecture about endoscopic treatment of lumbar disc herniation is if conservative is not enough and if you need a surgical management. The second question always is if pain physician is as good or good enough or as good as a spine surgeon for this type of procedure. I've been trying to answer this question in different ways. I've been trying to advocate the pain physicians that we are used to do on daily, we're used to access on daily basis, foramen, spine foramen. That's why we are a suitable specialty to use endoscopes, transforaminally mainly. But then I decided that maybe to prove it, it's good to do a proper clinical study with the proper dates being collected. So we did clinical outcome of patients after endoscopic discectomy performed by two specialists. One of them was me, pain physician, and the second was a very experienced endoscopic spine surgeon from Germany. We compared our results and finally we published this article. You can find it easily. It was a lumbar spine herniations, mainly transforaminal approach. 12 months follow-up. We were evaluating leg pain, back pain, osseous disability index, relative risk of complications. We included 160 patients divided into 80-80 plus minus, pain physician and a spine surgeon, and then we did a minimum 1 year follow-up in the study. You can see the results before the operation, after the operation on leg pain, 1 year follow-up, back pain, 1 year follow-up, and osseous disability index, 1 year follow-up, and then complications. As you could see, there is no difference in clinical outcome of both a spine surgeon and pain physician. Both clinical outcomes are showing, let's say, excellent improvement of the clinical symptoms on 1 year follow-up. Regarding complications, also there is no difference, let's say, and there is a paradoxical thing that a duropuncture happened within spine surgeon group, but it only once, and there was no consequence of this duropuncture anyway. Reherniation rate is similar, reoperation is similar. Overall percentage of disc reherniation was no more than 6.38%. So I can say in the conclusion that it's an appropriate method for pain physician if he is, and that's very important to mention, adequately trained. Pain physician must manage intraoperative bleeding, of course. That's why you prevent postoperative bleeding if you are able to do it, but it's not so difficult if you know how to do it. Pain physician must manage postoperative complications, type pain, reherniations, duropuncture, discitis, wound infection. Pain physician doesn't need to manage maybe postoperative epidural hematoma or epidural abscess, because this is the complication which belongs to hands of spine surgeons or neurosurgeons. And it can happen also with epidural anesthesia. Anesthesiologists can cause it, or neurologists can cause it with lumbar puncture as well, using a diagnostic for diagnostic purposes. Risk of hematoma also is always spinal cord stimulators with other procedures. So that's what I would suggest. And I would like to give you a little bit more details about transforaminal approach, technical and anatomical considerations. Endoscopic transforaminal approach, I use a Maximor system because I like some special parts of it. I will explain a little bit more in details in the next few minutes. The good thing is wide range of indications. You can treat extraforaminal, foraminal, lateral recess, anterior epidural space, and posterior annulus problem. You need to be extremely familiar with anatomy of the foramen. So Cambin's triangle is your mandatory thing to manage 100% in details because you're working here. And what you see is also the part of superior articular process you are supposed to take away when you are approaching the foramen and going inside the epidural space. You need to know anatomy of the spinal ligaments within the foramen, blood vessels, and so on and so on. So you really need to be an expert in foraminal anatomy, which is good to know what you're doing, what you're seeing, and what you're dealing with. Then you need to plan your trajectory extremely well, because with endoscopy, if you don't plan the trajectory correctly, you miss the fragment and you will miss then the correct clinical result as well. So you need to know where the disc herniation is placed, is positioned. So if it's at the level of disc, above the disc, below the disc, then you need to know how to plan the trajectory. It's a little bit of joystick mechanism. The other thing is you need to know about posterior propagation, cranial, exceptorocranial, and caudal propagation. So you need to know where it is in an epidural space, if it's central, paracentral, preforaminal, foraminal, extraforaminal, and then if the posterior propagation is grade 1, grade 2, and grade 3. According to this, you are planning how to deal with the herniation and with your trajectory and how to access it correctly. If you know this, then you're using some instrumentation. I really like what Maximor is offering in form of drills, manual drills or manual rimmers, where you can really you can safely land on superior articular process, take a little part of superior articular process, which helps you to open the foramen better for the future as well. So you're doing some kind of foraminoplasty. And then when you are accessing the epidural space, you are accessing in a very safe way because you are controlling with your optic vision where the nerve is. You're not going to the foramen before you are able to control the foramen with your optic vision. So first, you access the bony surface of superior articular process. You have different type of geometrical anatomical calculations recommended with different type of expert in the world. My experience is the easier way to calculate your entry point is your MRI image, where you are able to know exactly where the herniation is, and you can calculate your measures according to the MRI picture easily and very effectively as well. Then if you have, for example, this type of herniation with a caudal propagation going behind the whole vertebral body, someone will tell you that it's not possible to access endoscopically. It is, it's just correct planning. You do the skin entry point, you go with the first instrument, you enter the superior articular process. You always check in AP and lateral position. You have a correct entry point, which is a crucial part. The Tom Sheedy placement is a special instrument similar to the bigger needle. If you correct Tom Sheedy correctly, then you do the whole surgery correctly. You access correctly the epidural space. You get your first instruments where it's supposed to be. And then you just go with drilling. You're opening foramen with a couple of drills up to most often 8 millimeters. You're placing your working sleeve, and then under optic vision with a grasper you are taking out your fragment. This is how your endoscopic picture looks like. So you have a very nice view, you see what fragment is if you know what it is, and then you're just like taking out your fragment. You're checking your epidural space. If there are no more fragments, you would like to see that there is a good pulsation of nerve structures and there is no bleeding. If there is a bleeding, you take care of it and then you close the wound. And this is your result. If you would like to know a little bit more about under endoscopy, endoscopy results, we have performed plus minus more than maybe 10,000 endoscopic procedures in Slovakia and Czech Republic. We selected plus minus 800 endoscopic discectomies for some type of evaluation of pain and quality of life analysis, and we did it in a minimum 1 year follow-up as well. We did all the, you see that we did it on lumbar levels, and then this is plus minus similar results I showed you on the comparison of spine surgeon and pain physician just on a bigger group here. So it was very good improvement of low back pain, very good improvement of leg pain, and very good improvement of quality of life with similar reherniation rate we did in the first study. Here was more complex evaluation of the patient status after in a 1 year follow-up. We checked the mobility, self-care, usual activities, pain, discomfort, anxiety, and depression. And I think this is the group of patients you can see almost miraculously good clinical results, which is very satisfactory for pain physician in his job, where not everywhere you see those types of results. And then we have also some different situations, different indications I would like to mention. For example, scar tissue. There are a lot of discussions what you can do with scar tissue. It depends how much scar tissue you have. What is the clinical relevance of the scar tissue? This is a special case. The patient after fusion, as you see, with radicular symptoms, no MRI picture of any reherniation. So I went and did endoscopic revision of the foramen, which is not always possible, but very often it is possible. And then I got a picture of massive pathological tissue within the foramen. And this is not possible to manage with any type of catheter techniques or epiduroscopy. It's just mechanical thing where I was taking cautiously away the adhesion tissue, the tissue, pathological tissue from the foramen. And the final picture I got was the movement of the dural sac. When the neural structure started moving, pulsating, actually the patient suddenly, because it was under local anesthesia, felt a significant improvement of the pain problems, of the pain in his leg. And since that has been more than 5 years, and I can tell you the patient is still without any pain. So it's maybe the answer also if you ask me if this pathological tissue is not coming back. In 5 years, the patient is doing well and there is no problem so far. Then is another situation. If you have a look at this MRI, you can ask me what is wrong with this MRI. And I'm saying that there is a little pathology on L4, L5 disc, but the pathology is maybe not for surgery. It's not if the patient is not an elite Swedish cross-country skier with a need of a lot of training load, physical load, and if the back pain is not causing so much trouble with some kind of radiation into the leg that she is not able to perform her job, which is elite skiing. And again, there is a different type of presentation about discogenic pain maybe, but I can say that this lady, it's a different group of people, elite sportsmen, when they can have a combination of discogenic pain and radicular pain with very little MRI changes, and it's different type of treatment on such a kind of cases. We have a series of more than 20 elite sportsmen with similar MRI you have seen here, and we're collecting more and more data on this. And here we are doing some kind of transforaminal endoscopic approach with thermal annuloplasty of the disc and denervation, endoscopic denervation of the basovertebral nerve, with so far interesting clinical results where all our elite sportsmen came back to training. So this is another option, another type of management where you're not focused on a fragment, on a disc fragment, but you have clinical symptoms of back pain combined with some kind of radicular pain without proper correlation with the disc herniation. And it's also type of consideration what you can do instead of disc replacement and fusion, which is recommended as a gold standard. But if you use this type of management, like a radical surgical management on elite sportsmen, with the damage of the posterior compartment of posterior muscle compartment, the person will never come back to normal sport, and the risk of complications in form of post-laminectomy syndrome is very high. And the question is, why to use such a big weapon on an MRI like this lady, for example, had. Another group is adolescent disc herniation. Adolescent disc, this is an MRI of one of my patients here. You see the disc herniation on the left side, L5S1 disc, with a correlation with clinical symptoms over 6 weeks, with a deterioration tendency, motor and sensory deficit, continuous pain, 24 hours a day, 7 days a week, worse at night. And the biggest problem was, it was a young lady, couldn't attend school, couldn't carry on studies, couldn't live a normal life. That's one thing. The other thing is, when you go to any type of literature and experience on adolescent disc herniation, you will find out that the resorption, because of different type of quality of the disc herniation, is a very low chance that it will resorb spontaneously. So you either need to do a surgical intervention, or if you leave it like that, there is a high risk of permanent nerve damage and permanent complications, which is not a good option as well. This young lady, she had a previous medical history of no trauma, no comorbidities. The only problem was she gained 20 centimeters in 6 months. She was referred to a neurosurgeon, no indication for surgery because of MRI. Finally, we did this percutaneous endoscopic lumbar discectomy, took out this with this type of final incision on her body, so she's still able to take pictures for any time of fashion job in the future if she decides so. But this is the result, and the same thing is 5 months follow-up. Now we have her on 12 months follow-up, no medications, no clinical problems, no pain. She's back to usual activities. So it's also a special indication to think about. Complications. I would say you can have transient paresthesia, which disappears within a couple of weeks. Intraoperative bleeding, you can see, but you can take care of it. Turasactyr, very seldom, but of course it can happen. Then, of course, there is a small risk of postoperative hematoma. Several cases of surgical instruments broken during the surgery. And of course, I think the biggest problem can be the infection, mainly the disc infection. So every year I have 2-3 cases of spondylodiscitis. And this is unfortunately impossible to avoid. I think if you say you do a disc job on a bigger amount of patients and you have never had discitis, I would say most people who say so, either they lie on numbers of cases they perform, or they lie on they did not have a spondylodiscitis, because I say, yeah, and I know all the spine surgeons or pain physicians dealing with disc job, they have 2-3 cases of spondylodiscitis every year. Unfortunately, it's impossible to avoid so far, despite you use antibiotics, prevention and everything. So this is maybe the most common and the most complicated thing happening in a hands where you don't know what you're doing. Of course, you can also perform injury of lumbar sacral plexus or aorta or abdominal viscera when you really don't know what you're doing. But this is very unusual complications, and I'm just showing it to emphasize that if you're dealing with this type of job, you really need to have an adequate training and perfect knowledge of X-ray anatomy and endoscopic anatomy to know what you're doing. Radiation is not a big deal as well, because on transforaminal cases, whatever you're doing, you're not exceeding 60 seconds of radiation time, and sometimes you really work with like a couple of seconds time. So if you know what you're doing, you don't need radiation almost at all. So let me conclude this lecture. I would like to encourage you to start thinking about this endoscopic procedures, to use them. If you don't use them, and establish them into your pain physician's portfolio procedures. It's a minimally invasive procedure. You can do it under local anesthesia with or without sedation, depends on a patient. Very fast recovery. We normally do it on outpatient basis. Wide indication. You can take care of recurrent herniations even after open surgery. You can take care of extraforaminal herniations, which is not easy with open surgery. And also you can work with foraminal stenosis, discogenic pain, and sometimes synovial cyst if you need so. So it's a nice procedure and I fully recommend it. And if you are not interested only in endoscopic procedures and endoscopic management, let me kindly ask you or invite you for our management pain series, where we would like to teach people advanced ultrasound pain procedures. And we also would like to introduce 7-star scope, which is a combination of endoscopic and ultrasound guidance, endoscopic guidance and ultrasound guidance for different type of pain procedures. So if you have nothing better to do in November 10 and November 11th, you are welcome to meet our international faculty in Prague. And even if you like beer, you can have an excellent Czech beer there. So thank you very much for your attention. And for the last picture, I have chosen a couple of pictures from beautiful mountains of Slovakia, just to show you how my country looks like. Thank you very much once again and have a nice day. And if you have any questions, I'll be available to answer them. Thanks.
Thank you very much, Robert. It's as usual, very clear and very straightforward and comprehensive lecture and explanation with case scenarios. I'm gonna look for some questions from the panel, and just waiting for them to post some questions. Just one question for you regarding patient selection. How do you feel it's something important for your outcome? Is it something you mentioned and you felt from the beginning when you started your work on endoscopy, or with time you get more and more precise criteria for selection?
Yeah, you know, when I started doing this interventional pain diagnostic and management, one of my main teachers was Dr. Sheru Nath from Sweden. He's actually from Sweden, but originally from India, one of the father of radio frequency generation maybe in the world. And I spent a lot of time on facet joint diagnostic because it's Sheru's baby. But except for the facet joint diagnostic, the main thing from him, the main message was always, Robert, before you do anything on the patient, you have to make your diagnosis. This is the most important thing, because it's like in any kind of surgical management, you can have a curable patient if you make a correct diagnosis, or you can manage the patient symptomatically if you don't know the diagnosis. And the biggest tragedy for the patient is if a curable patient is in non-curable symptomatically managed group, because you don't take the cause of the pain problem. And you can do it the same as you can do within any kind of surgical specialty. If you have inflammation of the whatever, so you take the inflamed part of the body outside, and you're not giving the symptomatic management of the patient. So I've been doing this diagnostic, and then of course, if I found the generator, the pain generator, I was trying to treat the pain generator on the basis of proper diagnostic process. But for many years, I was missing what to do with the disc, because I was not a spine surgeon. So when I got one of the simplest diagnoses within the pain world, a radicular pain caused by disc herniation, I was always forced, if the transforaminal epidural was not working for a long time, to send the patient to the spine surgeon. And really, if you don't have a perfect collaboration with a spine surgeon, then the patient is just sent into the world of different specialty, where you are trying to do your best, then you send the patient to the other specialist, and the other specialist is saying, okay, yeah, I don't know, maybe a waiting time is 3 months or something like that. And then it's not working. So my dream was to get everything under one roof and maybe into the same hands, because then you can follow up the patient. So I did something with a friend of mine from Romania. His name is Ovidiu Palea. We actually went to first course of endoscopic discectomy 10 years ago to Germany, and we started performing first endoscopic procedures. And we realized for a pain specialist, especially the transforaminal approach is very natural, because you access the foramen on daily basis or in your work. So it was not so difficult. But you ask about indications, I always exclude everything, because radicular pain and facet joint pain, it can be very similar. And I think it's mandatory to exclude facet joint pain before you make your move to the spine, to the endoscopic surgery. But then, yeah, we don't have enough time maybe to discuss facet joint pain and discogenic pain. If the discogenic pain is first, or facet joint pain is a consequence, or facet joint pain is first and the discogenic pain is the consequence, or they just come parallelly alongside each other. So yeah, it's a very complicated thing, but I would like to do my best to set up the diagnose, to treat what is simpler first. So facet, in my opinion, is easier to treat than disc. But if I have a clear correlation with MRI, I don't do facet. I go directly to the endoscopic procedure on a disc if the transforaminal is not successful for long time pain relief. And also when you do endoscopic facet joint, when you do endoscopic disc surgery, you automatically denervate the facet at the level of the surgery because of the endoscopic transforaminal technique. It's like that, yeah.
Perfect. Great. I have a question, and I was thinking that you have been mentored by great teachers. And how do you think about learning curve? Dr. Issam Hamid, who is a colleague of mine and a great pain physician in Kuwait, is asking how many I need to do to be confident to
I can answer this easily, because I have trained in Slovakia a couple of pain doctors already, and depends on your talent, of course. You have to have a talent for this. If you don't have it, you will never learn it properly.
Yes.
But the thing is, to manage the access technically for transforaminal surgery, if you have previous experience of transforaminal injections, you need plus minus 50 cases under supervision to manage the access. This is the first part. But then to become a really self-confidence and self-working, you need to manage endoscopic anatomy properly, and you need to face different situations. And I think you need no less than 3, 4, maybe even 500 more cases to really know what you are doing and to be able to manage any situation without any backup. So the learning curve finally would be, if you perform at least 20, 30 surgeries a month, I would say maybe 3, 4 years. For a really like a professional endoscopic pain physician or surgeon or specialist. But access is very quick. Under supervision, if you have talent, good hands, and good teacher, you'll be able to access the foramen and to do the discectomy under supervision within I don't know, 30, 50 cases. I can say our doctors in European clinics, they are working, they are able to work independently plus minus after 1 year of supervision, working under supervision.
Great. Perfect. Since we're talking about regenerative medicine more and more, and you can see it in the literature and around us for our practice. Do you inject any biologics in the discs when you finish your work?
No.
Question from our friend from Iraq.
It's a very good question, and I answer no, or better answer is not yet. You know, I've been thinking how to do it properly. What is the good indication? I know that it's a separate lecture about stem cells and regeneration of the disc. And I think on special indication and special circumstances, if you know how to do it, it's a good idea, but it's not as easy as people think that I inject anything inside the disc, any disc, and everything will work. But I think it's a good idea, but this idea needs to be perfectly prepared, theoretically and practically. And if I start doing it, and I'm planning to start doing it maybe this year, I really would like to do it in a perfectly structured manner and to come with good results. So I've collected information. I've been trying to collect as good information as possible, and this is one of my plan, a future plan in a near future to start doing. What I'm not doing, and we try to do something with a PRP, but I think PRP and disc is not what is a good indication for a really good clinical results. But I think stem cells can be a good option. But
we have experts later with Dr. Al-Majid is going to talk about this, and I'm gonna maybe disclose we're working with Dr. Sudhir Diwan from the US and Dr. Anu from California on a work on trials and comparative studies with stem cells and spine. So we'll let you know the results.
Yeah, we are trying with Dr. Diwan. With Dr. Diwan, we are trying to connect and maybe to start doing it too, because I know that he has done a very interesting work on it, and he is one of my potential future partners for this job because he already has more experience with that. And I've seen his lectures, very good experience.
Yeah, great. Can I probably get another? Yes, there's a question regarding regenerative medicine. Maybe we'll keep it later for Dr. Abdelmajid. Lots of questions that I'm trying to select a little bit. Okay, and probably everyone is asking about regenerative medicine, so maybe we can shift to the second talk. And if you're still here, otherwise I can send you messages and get your answers. Thank you very much, Robert. It's always great pleasure to see you, and maybe see you next week if you're there.
And maybe not see you, but anywhere see you.
Okay.
Future. Okay. Thank you very much for the invitation.
Take care, Wiz. Perfect. Great. So let me introduce Dr. Abdelmajid, who is a great speaker and consultant in hematology. He has the American Board of Regenerative Medicine and head of regenerative medicine section in one of the biggest hospitals in Baghdad, Iraq. I have the chance to meet him and to discuss with him and to learn from him. And it's a great pleasure to have him with us. And one thing that we learned from the COVID, positive, at least something positive from the COVID, is the Zoom that can connect people from all over the world. And I'm glad we had like 1,400 people registered. And it's great to have Dr. I don't know where is he now because he works in Iraq, but he told me that he's traveling somewhere in Egypt, I think, and he's connected. Thank you very much, Dr. Abdelmajid, and the floor is yours, please, if you can share your slides. We need you to unmute yourself, Dr. Abdelmajid. Yes, thank you.
Is it okay now?
Yes, perfect. Great.
Okay. Thank you, Dr. Ammar. Really pleasure to have this meeting with the good number is 469. Thank you, Dr. Robert. And now I will start my talk about regenerative medicine. Is it okay now, Shell?
Maybe
Yes,
not yet.
go ahead and share.
Yeah, you can share. Yeah, you can share your slides.
Just see. Can I share here? Or it's not
Yes,
obvious.
you
No?
just on the bottom of your screen you can share.
Mhm. I will see.
Yes.
No. Is it okay now?
Not yet.
Not yet.
You have the share screen on the bottom, and then you can open your yes, PowerPoint. Yes, perfect. Slideshow.
No, it's okay?
Yeah, but you need to have the slideshow now.
Okay. Now,
Yes, perfect. That's great.
okay. We start now about cellular products for regenerative medicine. Now, this is a new sort of medicine. As a definition, it's a process of creating living functional tissue to repair or replace tissue or organ function lost due to age, disease, damage, or congenital defects. It helps to produce healthy longevity. It is one of the science that will be basically the main medicine in the future, because it applies translational research in order to solve many clinical challenges. Usually, the treatment in the classic medicine depends on drugs or physical factors, radiation, etc. But for regenerative medicine, you use the cells, you use tissues, and you can use organs. So what we have is something called minimal manipulation on the top, which is approved by the FDA. And there is the other technology like nanotechnology, immune therapy, gene therapy, tissue engineering, and 3D bioprinting. Now, what we have types of stem cells. We have the embryonic stem cell, which exists with the earliest stages of development. And we have the adult type of stem cells. Where are the sites that we can use in the adults? We have the bone marrow is accessible, the peripheral blood, the adipose stem cells, the dental pulp, endometrium, and cord blood. All these are sources of adult stem cells. The third type is what is called induced pluripotent stem cells, which is a form of adult cells that have the capability of embryonic. Now, what products we have? Because our main lecture is the address is the cellular products. So what cellular products you can inject? Now, you know we have the mononuclear cells, and those mononuclear cells can be separated from the bone marrow, from the peripheral blood, or from the cord blood. From the bone marrow, you can use it by centrifugation or by filtration. So we have the bone marrow, we have the peripheral blood and cord blood to get the mononuclear cells. Mixing the blood with Ficol and then centrifuge, you will get a product of mononuclear cells, which is lebaficot. So you have, as we mentioned, in this picture, you can see that there is the first, at the top is the bone marrow aspiration. The second is that the patient is connected to a machine, which is called blood cell separator. And this usually we give what's called granulocyte colony stimulating factor, so that to bring the cells from the bone marrow to peripheral blood, and then you can collect it in this machine. After getting these cells, you can use it. The third one is the cord blood. And usually the cord blood volume is small. This is Matthew. We met in Dubai this year, and he is the first person who received, he is the first patient who received cord blood transplantation. It was experimental, and he is now in his 30s in healthy status. Now, bone marrow stem cells during with the newborn, usually it's around 1 in 10,000 mononuclear cell, but with the passage of the time, at the age of 80, it is 1 in 2 million. So the cells, the stem cells will be reduced in the bone marrow with the age. How can we assess, or how can we count and sort these cells? We use the machine flow cytometry. So it can count and sort and biomarker identification. That's to say, to identify the cells, to count them and sort them. Now, there is a special type of cell. It is called multi-lineage differentiating stress-enduring cells. It is Muse. Muse is subpopulation of mesenchymal stem cells. It is similar size to the mesenchymal stem cells and similar general surface markers. In addition, it forms cell clusters when cultured, and it has high survival engraftment capacity in diseased tissue, especially with increased hypoxia and acidosis. So it resists the stress. In addition, it has embryonic capability, embryonic stem cell marker. That's very interesting. It's present. Where can we find these cells, Muse cells? They are found in the bone marrow, in 1 in 3,000 mononuclear cells. 1% of bone marrow mesenchymal stem cells is Muse cells. If you have 10 cc of bone marrow, it yields approximately 1 million in 10 days, 1 million cells in 10 days. Other than the bone marrow, it's also available in the adipose, connective tissue, and peripheral blood. Now we shift from the bone marrow to the adipose. So when you excise a part of native fat, or you aspirate a lipoaspirate, you have what is called, you process this lipoaspirate or fat, and then you can produce what is called stromal vascular fraction. What is stromal vascular fraction? It's a cocktail of cells. It contains mature cells like adipocyte fibroblasts. It contains progenitors, especially endothelial progenitor cells, pre-adipocyte vascular progenitors, and also stem cells. And in addition, pericytes, which is a very important part of regenerative medicine. Now, from where we can extract this stromal vascular fraction? From the adipose tissue. By which method? We have classically the mechanical, enzymatic, and then the ultrasound method. Now, adipose-derived stem cell, which is contained inside the what we call SVF, stromal vascular fraction, it has majority of criteria for MSCs, which is CD90 positive and CD70, but it's negative for CD34. It's usually available in the capillaries and adventitia of blood vessels, and also in large blood vessels, they exist as specialized fibroblasts. Now, those steps, though they are lengthy procedure, but we did usually extract SVF from the adipose tissue by enzymatic method. This is the enzymatic method. You use collagenase and you dilute, and then you add it to the adipose centrifuge, shaker incubator, centrifuge, and then you extract the stromal vascular fraction. And this needs around 17 steps to get this stromal vascular fraction. Now, and there is also the mechanical method and ultrasound. Now, if you look here, what we have here is the stromal vascular fraction. This is isolated in our laboratory, and you see the whitish part in the bottom. This is the stromal vascular fraction, which we extract usually. So it's a small volume and usually extracted here. Now, also this is in our lab. Those are mesenchymal spindle shaped mesenchymal stem cells. You can get from the stromal vascular fraction, from the bone marrow, from the teeth, or from the endometrium. Now, we shift to the exosome. If you know, some people definitely will know about it. Exosome is 40 to 100 nanometer in diameter, is a packaged vesicles secreted by multivesicular bodies, is usually released by exocytosis and encapsulated by bilayer membrane. It has unique marker like CD9, CD63, or CD81. Now, what's the function of those bodies, which are extranuclear, intracellular? They can transmit macromolecules to other cells, and they help in cellular communication. It has a wide variety of uses nowadays in neurological disease and in different diseases. Now, exosome can be isolated from the bone marrow, from mesenchymal stem cells, or from peripheral blood stem cells. Now, umbilical cord MSCs, they have high telomerase activity, lower number of bone marrow, lower number than bone marrow MSCs, and higher proliferative potential, and high immune modulatory activity. Now, umbilical cord blood is a source of transplantable hematopoietic stem cells. So they are used where in the bone marrow transplants, okay? Now, the MSCs have different, description. Kaplan in 1987 described it that is the most important stem cells type and driver of tissue regeneration. But now, with the recent one with Kaplan, also in 2011, is known as medicinal signaling cells rather than a true stem cell. So it is an immune modulator also, and highest potential of MSCs in orthopedic applications. Now, mesenchymal stem cells usually have the markers, 3 main markers, CD70, CD90, CD105. But CD34 for the hematopoietic is negative usually. Usually can be extracted when they have affinity to adhere to the plastics. This is the isolation technique. Somewhat immune privileged, and it has immune modulatory effects. Usually the highest MSC density in the adipose tissue of the lower abdomen. So the ideal stem cell culture environment, usually safety, cost effectiveness, controllability, intact cytokine pathways, genomic integrity, and intact cell signaling. Now, we shift to the PRP, which you well know, the platelet granules, the lysozyme, the dense granule, and the alpha granules. Now, the alpha granules usually 200 to 500 nanometer in size, and usually comprise 10% of the platelet volume and develop in the megakaryocyte and continue development in the mature platelet. Now, platelet activating mechanism, you can memorize 3C: calcium, collagen, and cold. Calcium, collagen, and cold. Thrombin also is a good stimulator. Now, platelet activation, tissue collagen is the most potent activator of platelets. Now, the PRP usually attracts stem cell. It is not a stem cell. PRP is platelet-rich plasma, platelet-rich plasma. It's not a stem cell, but usually attracts stem cell. It has the capability of stem cell homing, migration, adhesion, and then differentiation and proliferation. And we have a lot of growth factors secreted by those platelets. Now, when you have a wound, you have the stage of inflammation, then proliferation, and lastly, remodeling when you get collagen and fibroblasts. Now, the optimum concentration of platelets for stimulation of angiogenesis is 1.5 million. But when you go above 3 million, you will have inhibition of angiogenesis. Sorry. Now, we talked in conclusion, the leukocyte poor PRP results in improved functional outcome score compared with hyaluronic acid or placebo when used for treatment of knee osteoarthritis. Now, bone marrow MSCs versus adipose. Majority of adipose MSCs are adipocyte precursor cell. That's to say, when you have bone marrow MSCs, usually goes with the osteocyte differentiation. But the differentiation potential of the adipose MSC favors adipocyte differentiation. Yani, that means the adipocyte goes to adipocyte differentiation, and the bone marrow MSCs goes to osteocyte precursor. Now, efficacy of mesenchymal stem cells for management of knee osteoarthritis. This is a systematic review and meta-analysis. In conclusion, there are 7 randomized trials. MSC injection, which is mesenchymal stem cell injection, could be potentially efficacious for decreasing pain and may improve physical function in patients with knee osteoarthritis. Now, the role of cell therapy in osteonecrosis of the femoral head in 7 studies, meta-analysis conclusion, addition of bone marrow aspirate to core decompression, especially in early avascular hip necrosis, would improve the survival of femoral head and reduction in the need for total hip replacement by 50%. This is very important study. Now, there's what's called nucleus pulposus progenitor cells, which is phenotypically very similar to bone marrow MSCs. And there's a synergistic effect between the MP and the bone marrow MSCs. Now, lumbar intradiscal PRP injections, prospective double-blind study showed significant improvement at 8 weeks. Promising results, but more data is needed. There is some sort of stem cell which is present in the tendon of the muscle. It is called tendon stem cells, which is 1% of the total nucleated cells, quiescent under normal conditions. Differentiation can be induced by mechanical factor and marked loss with age and degeneration. Now, natural killer cell is now getting attention and more focus as immune therapy, and that can be used for immune therapy in cancer treatment and other treatment. Now, we have committed cells, I mean differentiated cells like neuro, progenitors, cardiac, endocrine, renal, and even hepatocyte. You can use it for regeneration. Now, what we have to have efficacy of the product. How can you get this product in better action? It depends on the count, how many cells, viability, are they viable or they are dead, the potency, multipotent, pluripotent, unipotent, and the site of injection. So all these 4 criteria to attain a very good response. Now, what we get available techniques inside the rack, we have the stem cell harvest, which we use the blood cell separator. This is one. And the second thing is the bone marrow harvest. We have the adipose-derived, the enzymatic, and the ultrasound kits. And we have culture cells. Now, our experience dates back to 2008, when we started cases of multiple sclerosis, and we selected mainly the progressive cases, not the relapsing remitting. And we got a good response. We used the cell separator after giving granulocyte current stimulating factors. Also, we used bone marrow, and in few cases, we used adipose-derived stem cells. So that was the sources of the cells for multiple sclerosis. The response, most of the cases were of the primary or secondary progressive. And the response was 77% improvement in the EDSS score, which is the score for multiple sclerosis. For the spinal cord injury, we have a good series also published in 2012. That's 10 years ago. We published an article of people with spinal cord injury, but most of them were in the real practice advanced cases. And we saw the difference, but it was mainly related to improvement in the liver, the sensation will drop, the dermatome will go down, and improvement in the sphincters. For the motor function, very rare to have the improvement. Now, for epilepsy, resistant epilepsy, people who use more than 2 or 3 drugs, and we have 23 patients, we got response and improvement in 60% of the patients. For diabetes, we got also many sources like the bone marrow, and you can inject to the IV, or you may inject it through the arterial, through a catheter. And we have a good type of improvement. What we need here is that the method of administration, intravenous, subcutaneous, intramuscular, intraarterial. Now, what we want to reach is the partial remission of diabetes. We have a special formula, or so that you can know if that patient had a partial remission, because total remission is very rare. Now, for cerebral palsy, also we have cases of 242, and we got improvement in 45% of those patients. In stroke, we used intraarterial approach, bone marrow-derived cells with Dr. Fadel, and we got improvement. That was one of the important articles that were published and showed improvement in people who have subacute or chronic stroke. For orthopedic cases, me and Dr. Khalil Jum'a, who is very excellent person in this regard, so we registered two clinical trials. The first one is the use of bone marrow aspirate concentrate to treat knee osteoarthritis. We registered it under this national clinical trial in the website of the clinical trials US. And the other, we registered bone marrow cells with core decompression for AVN, avascular necrosis. 10 cases registered also, and we got a number for it. So it is approved. So we have 2 approved clinical trials now for Iraq, one about bone marrow aspirate concentrate for knee osteoarthritis and the other for AVN treatment. And also we got success for people with hemophilic erythropathy, with target joint. We used ADSC, adipose-derived stem cell, for treating hemophilic erythropathy with very good results. Now, for fertility issues, we have a good number of people. We did with Dr. Assam, urologist, and other people who are who worked with us as a team. We have a male patient who responded in 2018, who was a case of spermatogenesis arrest, who responded to a stem cell injection, and he is now fertile. He got 2 children. The other case was we got now 2 cases of female patients who have premature ovarian insufficiency, and we got a very good response. That's the AMH, the anti-Mullerian hormone, is increasing, estrogen increasing, FSH decreasing, and also we got proof by ultrasound of growing follicles inside the ovary. This is very recent, and we will do a case report about that. So for fertility issue, it's very good. Now, we got this patient with rare syndrome, which is hereditary palmoplantar keratoderma. So 1 injection of intravenous bone cells, and he got improvement in the, he was a British person. I did the first stem cell treatment for MS, and he insisted that he do a press conference at that time, 2009.
بعد معاناته لسنوات من حالة التصلب الأعصابي لم يتوقع الطبيب الإنجليزي كارون أندرو أن يحصل على العلاج الذي منحته إياه إحدى صالات العمليات في بغداد. هذا ما أعلن عنه أندرو خلال مؤتمر صحفي عقد في بغداد بعد نجاح عملية فقد الخلايا الجذعية في الحبل الشوكي لعلاج حالات التصلب الأعصابي التي أجراها له الطبيب العراقي عبد المجيد علوان، والتي أثبتت إمكانية ارتقاء الطب في العراق رغم الظروف التي أنهكت الواقع الصحي.
It's wonderful to be here.
هنا في بغداد حصلت على علاج لا يمكن أن أحصل عليه في مكان آخر.
So this one, he responded to peripheral blood stem cell injection, intrathecal, and he got very marked improvement, as his neurologist said. This was we did first allogenic bone marrow transplantation in 24th January 2003. And after that, this picture is for the first autologous, that was in August 2004. This was Italian bone marrow transplant expert, and Dolina Marino, and Dr. Ala Makki, me, and Dr. Ahmed. So that was in 2004. And here is another patient with multiple sclerosis. We have many inventory patents in the field of regenerative medicine from 2001 till 2022. Dr. Khalid Juma, he's been an intensivist, and he has many good new ideas and inventions. And in Al Zaytun, which is a private hospital in Baghdad, we have a team of many specialties all over the world. And we have this was one of the response to our treatment strategy. So thank you so much. Thank you all for listening.
Very good. Thank you very much for that excellent presentation and sharing experience on 20 years, almost 20 years of experience. So we cannot dream better advice from your side. Dr. Abdul Majid, Dr. Khalil also present. They work as a team, and many questions. One of them is, when you inject, do we have rejection, Dr. Abdul Majid? Any risk of rejection?
It is autologous, as the FDA approved the minimal manipulation, autologous, so no rejection. But reactions, yes, you may have for you inject intrathecal, you may get headache or meningism. So this is expected.
Yes. What are the major, let's say, side effects that you face during your experience when you inject and you do regeneration?
Most of them are safe. We didn't came across an important reaction. Most of them are simple. We didn't have a major problem.
One question, how do you explain that despite the fact that we have more and more papers and evidence in the literature, still this field is not like spread enough in our clinical practice?
Yeah, that's a very good question, really, because when you inject cells like bone marrow derived or hematopoietic, they will have an effect, but the effect is not durable. Usually 1 to 3% will survive. But nowadays we are concentrating, we shouldn't make it every system. I mean, now we are concentrating on special systems that we have a good response, like in osteoarthritis, in sport injury, in plastic surgery, in cardiology. Now we have a good evidence, a good solid evidence. So premature ovarian failure, as you see, we did 2 cases and we got response. So I think we should concentrate on the promising field. The neurology is now not the, we didn't get a very good, you got a response, but usually transient. It's not a permanent. So we should concentrate on the system that get the best result.
Yeah. One question regarding PRP, Dr. Abdul Majid. Does the count, the number of platelets, important before starting to have blood sampling?
Yeah, definitely. Most of the people are sending the sample to the lab, and then this is the practice, the usual practice in Iraq. But you should count, you should do double spinning, and then you get the exact number, which is 1.5 million, as we mentioned, which is the convenient number. If you go above, it's not, it's a poor effect. Less also is poor effect.
What about leukocyte? Leukocyte rich and poor. How do you separate them?
This depends on the centrifuge, just the type of the centrifuge and the speed. There's no problem.
Okay. Then we have some other questions regarding most of the questions are asking about risk that you can have during, but you answered that. Any rejection from these injections, from these cells? Sometimes you said there is the reactions, but did you face any rejection, rejection, failure, complete failure?
We are talking in a new field, you know. The failure is expected, but rejection is not, because you are using the same body cells. There's no rejection, but you can have reaction. It depends on the site where you inject. We gave a lot of people intravenous, but we should filter. I mean, we have two types of filters. We have the 170 micron filter and we have the 10 micron filter. So we usually double filter and we put a proper anticoagulant, which is the ACD. It's better than heparin. And we use double filter. So there is no risk. You are using autologous cells. There's no embolism, no such problems. Most of them, 99% safe. And what you expect to have sometimes a sort of reaction and not a rejection.
I've seen a lot of work done in clinical practice, and from your own work, what is the time frame to expect regeneration, for example, for knee osteoarthritis, for example, after injection?
So for osteoarthritis, to get improvement in the WOMAC scale, pain score, function, is almost immediate improvement, maybe due to the PRP action, because you know bone marrow also contains platelets. And the other point is that when you got cartilage regeneration, it takes more than 6 months to have approved. Until now, let us say, there is no evidence that showed that the bone marrow aspirate concentrate or the SVF can cause, regeneration of the cartilage. There's not much evidence, international speaking. There are few reports, questionable, and in the early stages only, not in the advanced.
So how do you explain in this case the efficacy? How do you explain that all the scores are better, range of motion is better, although the cartilage is not regenerated?
So this is the, if you had seen the conclusion of multiple studies, it showed that there is improvement in the function and pain, but they didn't mention the cartilage regeneration, most of them, especially for those people, especially, I mean, this can be explained on the basis of cytokines and the growth factors, paracrine effect.
Okay, great. Just looking for, we have reached almost 500 people, and when it exceeds 500, the rest will be directed to Facebook Live. So it's amazing attendance, thanks to the speakers. And this shows the interest of this field, the regenerative medicine, and I think it's something important for the future. We have a very good question from Dr. Rubina from London. She has a very busy practice in London. She's saying that her personal experience is 17 years of regenerative medicine. Practice starts work in the next 2 to 4 weeks, and functionality is extremely effective in 6 weeks, after 6 weeks. So this is her experience, and thank you, Rubina, for sharing your experience. For Dr. Abdelmajid, he was telling that maybe 6 months is the optimal where you can see really the peak of the efficacy and the regeneration. Very good. So thank you, Rubina, for sharing your experience. Dr. Abdelmajid is also present with us. He's the man behind the curtains, let me say. Is always present in all these this work and amazing work. His comment is regarding the intradiscal, Dr. Abdelmajid, lots of questions of intradiscal bone marrow concentrates. How much you're gonna inject if you need to regenerate something in the disc cells?
Really, I have no experience. I just mentioned some of the results, but we didn't inject bone marrow into the disc.
Okay. So very good. So we have plenty of questions. I'm trying to select some of them which are relevant to our questions here. Very good. So what's your advice for people who are starting this service, Dr. Abdelmajid? How do you advise them to start regenerative medicine service in their departments?
As you know, there is a lot of malpractice all over the world.
Yes.
And including the Gulf and Iraq and anywhere. Regulations in our region is very weak, and you cannot discriminate between the solid base and the others. So I think it's the first thing is to have the American Board of Regenerative Medicine. It has a very good theoretical basis. You start with this, and then you start practicing simple things like PRP, and you go to other one-on-one other techniques.
Yes, great. Yeah, this institution is amazing academic platform for those who are starting. I agree with you 100%. And I know that many of you in Iraq, you are certified in this prestigious educational platform. Great. So I'm not gonna take much of time of everyone. We exceeded 1 hour and a half of our time of our delegates, our attendees. Thank you very much for attending, and it's great to have you always with us. We're gonna share more insights on regenerative medicine in the next one with more practical tips and tricks with other speakers, and you will have a sort of evaluation for the CME hours, and then you can get your CME points afterwards by email. Thank you very much, Dr. Al-Majid, again. Thank you, Robert, if you're still there, and we'll be in touch, inshallah. Thank you very much. Take care.
Thank you, everyone.